If you go into the shell, you'll note that there are lots of videos. I urge you to read, to look at those videos. And the reason I do that is because they're pretty good, actually, about the material that's in them. This first week, the videos have to do a lot with the subjects we're going to be talking about, which is how drugs work, the pharmacokinetic, you remember, release, absorption, distribution, metabolism, excretion. There's all sorts of videos that cover that. We also, this week, we'll be talking about drug classification of anti-infectives. So there are some good videos about the mechanisms of anti-infective activity. These are important for us to know because different antibiotics work by different mechanisms of action. One of the strategies that's been used in treating infectious disease has been to use multiple agents sequentially, not at the same time. Antibiotics are kind of nasty because they tend to for bacterial and fungal diseases as opposed to virology. Anti-infectives tend to be very sweeping in their activity, and so what happens is you may have had some experience with this in your own life, but we urge people when they're taking oral antibiotics to take probiotics or yogurt or something, because the antibiotics kill off the gut bacteria. And gut bacteria are critical to our health. They're important to helping us digest food. They generate vitamins. They do a lot to help us. So we urge people to do that. Now, can we do a complete replacement using either probiotic capsules with billions and billions of organisms in them, or by taking yogurt? No, because we have a very wide variety of microorganisms. But have any of you taken Med 104 yet? Okay, so you've had some discussion about microbiology. You know the various classifications of microorganisms. Viruses are different in that there's actually a debate as to whether viruses are actually alive. But anything that can reproduce itself, I sort of consider alive. And that's what viruses do. That's their entire function. The problem with viruses is they're very different from bacteria. So antibacterials and antifungals have no effect on viruses whatsoever. One of the reasons we have a problem now with resistant microorganisms is that people, when we started getting drugs to treat infectious disease, they were overprescribed. And they were overprescribed because of a lot of reasons. Basically, doctors just overused them and bred resistant microorganisms. And that's come back to bite us rather hard. So viruses have no response. The problem with viruses is that unlike bacteria, we don't have any broad spectrum antiviral drugs, not yet. There's some research going on that may give us those broad spectrum antiviral drugs. We'll see. Research has a habit of taking many years longer than anyone thinks it's going to, and give us very, very different results sometimes. So we will talk about the differences and the materials that we have in your textbook. The textbook version we're using is is about 5 years old, and there is a new version that's coming available, but we won't be using that. We'll be using the fifth edition instead of the sixth of this book. It's pretty good. It's pretty general about pharmacy, um, but the sections on drugs are outmoded. So one of the things we'll be doing here is we'll be doing a project. Each of you will pick a classification of drugs, and you'll do a project looking at the current drug um, choices that we have, and maybe looking at as well at other things. I have a handout I'm going to give you so that you can start thinking about this. By the end of the week, we need to have you do that. This is different from the LRA. The LRA assignment here will be actually what we refer to as your chance to play doctor. You'll be given a case study, and it will describe a patient, their symptoms, the signs that we can measure. You all know the difference between signs and symptoms. So we'll have all the information, a little bit of history, demographic information about the patient, and you will be asked to come up with a diagnosis and justify it. Okay. Diagnoses in in the doctor's office can be tricky because, of course, many different diseases can have similar signs and symptoms. So that's the value of taking a good patient history as well, so that we can rule out certain things. And so you will do your best on this, but give it some thought. And don't hesitate, by the way, to consult with each other. What we'd very much like to see is students working together on assignments, helping each other. We call them study clubs. And you remember last mod, Joel came in and talked to each class about this concept of a study group. And we would like to see students engage in that. We don't want to turn it into a tutoring section. What we want to do is have it be an interactive group of students helping each other with their classes. Obviously, that has some difficulties in a school like this, work and everything else, but it is worth considering how you can do that. And it doesn't have to be face to face. You can set up a forum as well. So bear that in mind. One other thing, you may have seen the signs out here about work study. If you're interested in a work study position and have a 3.0 average or better, talk to Amanda. We are hiring one work study, do a number of things. It just depends. We need a lot of help here. We are short staffed, and work studies. We have a replacement for Andrew. Cody Smith is going to be doing the IT. He's going to get a little bit of training from Paul. He already knows a lot of it, but we just want to get him up and running. So he will be running the IT support. Anthony, bless his heart, has volunteered to help people if they call him. So he also is available, and we may actually see him on campus. So those are the couple of things I wanted to mention, was the change in IT and the fact that we are indeed hiring another work study. Again, if it's of interest to you, go talk to me. So let's take a look first at our first at the course shell and just do a quick look at the class. We'll talk about the LRA probably after the first break, because I think I want to get through this first. In the first week, what you will have as we'll be talking about again pharmacokinetic and pharmacodynamic principles. I've got some handouts on that. Looking at things that can affect drug activity. We'll talk about classifications of drugs and work with the drugs we have nicknamed the antis, basically the anti-infectives. Readings, chapters 10 and 11. Chapter 10 is called Basic Biopharmaceutics. Chapter 11 is factors that affect drug activity. Those will be the chapters. Read those. We'll talk about, we've got a couple of lectures. I've got some reference charts and handouts that I'm going to give you. And again, suggest that you watch some of these videos. If there's a problem with the video link, tell me. I have not tested them all out. But I will have some other things for you. So there are a number of different assignments. The grade book is going to change. It's going to reflect some of the other assignments that are not directly listed right now, such as some other quizzes and some other things that I want to work on. So that's basically the outline for this week. We will we'll be working on that in the same way as we worked on some of the things in 208, except that there's no labs in this class. So let's go back here now. So the homework, you'll have an assignment on pharmacokinetics. You'll have an antibiotic comparison chart that you'll have to do. And then you'll have a quiz. It says in the homework and assessments, it says this is an in-class quiz. It may end up being a quiz at home rather than done in class. We have a lot of material to cover. And then you have a discussion. We'll have 3 discussions the first 3 weeks. All of them will be irrespective of what may be said in some of the instructions. I haven't gone through and modified every single assignment here. Irrespective of what it may say in the instructions, the hybrids are, first post should be done by Wednesday night at midnight, and then your responses are needed by Sunday, not Saturday. Wherever you see a Saturday due date, Sunday is my due date. So if you turn it in and it says it's late and you've turned it in by Sunday, it is not late. Okay, so don't worry about that. Assignments are pretty much open throughout the mod. So if you don't get an assignment done by the due date, please do it anyway. Even if you lose some credit, you will get, it'll be, some credit is better than no credit. So please do it. Also urge you to stay up. As I said, there's a lot of work here. We have a lot of things to study in one 4-week mod. So we will be working on working from that schedule. This week's discussion is for you to choose one of the components of pharmacokinetics: absorption, distribution, metabolism, or excretion, and explain at least 5 factors that affect that component. So we will have we'll talk about the entire topic, but we'll also talk about, you'll also have some handouts that can help you with that. But do a little bit of research. And lastly, explain why it's important for you to know as a medical assistant. Now, some of you may not be planning to be medical assistants. This class is really geared toward the majority of our students end up getting the medical assisting certification. And even if you're interested in something else, if you're interested, say, in pharmacy, well, it's pretty important to that too. So so we want you to look at that. So again, get the first post by Wednesday midnight, and the last and the responses by Sunday at midnight. Earlier if possible. Okay. And for your assignments, let's talk about the first assignment is the antibiotic comparison chart. Basically, you're going to be looking at that chart, and the chart has a different set of types of antibiotics. We'll cover those in the lecture on antibiotics, probably Wednesday morning. But you're going to have a mechanism of action. All of these have a mechanism of action. It's called an MOA. Name recognition, in other words, is what we're looking at is related to a handout I gave you in 208 about the suffixes drugs. The suffixes to our drugs, the generic names of drugs these days, pretty much tell us what classification it's going to fall into. Like all of the penicillin-related drugs, ampicillin, amoxicillin, carcillin, etc., all end in cillin. And these are all related to the original anti-infective drug, penicillin. So what you want to do is see if there is a consistent suffix to those drugs. Cautions are the concerns we have about side effects or potentially contraindications. Remember what a contraindication is? A condition the patient may have which would make a drug inappropriate. One of the most common is patients in renal failure have trouble excreting drugs through their urine. So we have to be careful about using most drugs because most of them are excreted through the urine. So those are the kinds of things. Drug examples would be names. And here you can use trade names, generic names. Generic names are fine for a lot of drugs, but sometimes trade names is maybe what you want to do. And then the conditions treated. In other words, what kinds of microorganisms are being treated. Okay. And what diseases may they or may they not be associated with. Okay. So that's going to be the antibiotic comparison chart. The next assignment for the week is the ADME assignment, the pharmacokinetic assignment. the ADME assignment is that you choose a drug from the top 200 list. We'll talk about that list a little bit later. The list itself is varies from year to year because it's really about how many prescriptions are written. There's actually two lists. One is the number of prescriptions written, and the other is the sales of drugs. And they're very different lists. One of the differences is that drugs that are relatively cheap, like levothyroxine or Synthroid, which is probably the top-selling drug still in this country right now, in terms of numbers of prescriptions written, is cheap. So it doesn't have the sales of a drug like, say, Remicade, which is very expensive. So you have the difference between something that's literally pennies a dose versus something that can be hundreds of dollars a dose. And you can see that it doesn't take a whole lot of prescriptions for a drug with hundreds of dollars per dose to make a lot of money. We're going to stay with the prescription list, and that list is at the back of the book, old list. I think it's the 2010 list. So it's very different. If you look at that list, you'll see one of the top sellers is Lipitor, which is now off patent. It is no longer a top seller. But if you choose something off that list, that's fine. We will do that choice. Today, actually, after the break, I'll have a copy of this assignment for you to look at, so that you'll know how we're going to. You'll also know how it'll be graded. So, and it's due this week. So it's basically starting us on the process of looking at drugs. One of the things in pharmacy is, of course, where it's all about the drugs. Pharmacists are much better trained in drugs than are physicians. Not to knock physicians. They have many other topics to study. And they take their last really drug-oriented class in medical school in their first year. It's called human pharmacology, and that's where they study various body systems and the drugs that affect them. And of course, by the time they get out of medical school, that drug list is different. And it's very hard for them to keep up. So again, if you are interested in learning about a drug that you've been prescribed by a doctor, you might want to talk to a pharmacist because they know more about drugs than doctors do. Pharmacists only study drugs. I mean, they study a lot of other topics, general biology, human physiology, anatomy, and so forth. But they study drugs very intimately, so they know more about drugs than virtually anyone else in the medical profession. But they have to keep up on it. One of the topics that we look at often is we have new drugs, and new drugs when they come out are often being pushed very hard by the pharmaceutical industry, the sales reps, and they work at getting the physician to prescribe them. But we have very little. We have a lot of information, but we don't have years and years and years of experience with these. So when new drugs come out, the amount of information that's available is relatively limited. But nonetheless, we have to understand what they are, what they do, how they work, what their interactions are, what their contraindications are. So we study these things always. Hello, Katie. So we study all of these things quite a bit. But there also, please, you're doing an LRA. You're going to be doing assignments like this ADME assignment. You're going to do the drug classification assignment. Don't turn these into major theses. These are not meant to become a gigantic project. Basically, with the ADME assignment, we've got essentially a couple of paragraphs of information that you'll be presenting. You'll list all of your sources of information. Remember, we talked about various good sources of information about drugs, rxlist.com, drugs.com, webmd.com, which is part of drugs.com now, globalrph.com, the FDA.gov site can give you a lot of information. All of them have essentially the same information, just laid out differently. I personally use rxlist.com because I've been using it long enough that I can almost immediately find the information I want. With some of the others, I have to search a little bit. And since I'm lazy, I use the easy one for me. And I urge you to find something that works. You also have Hippocrates, which has good information, but it's much more abbreviated information of necessity. But it's also a decent place to start. But we also need to look at these. Again, it's due Sunday, not Saturday. The first 3 weeks, everything is due on Sunday. The fourth week, everything has to be in by Saturday night at the latest. I prefer it in earlier, like Thursday night. But the reason is that the mod closes Saturday, and you may or may not have access to your shell after that. Okay. So, and again, if you have trouble with submission boxes, don't hesitate to email your assignments to me. Okay. So, questions? Okay. Then let's go to the LRA assignment. Okay. The LRA assignment, we call it grand rounds. You know what grand rounds are in a hospital? That's where the doctors come in every morning, usually very early, and go and discuss patients with the nursing and hospital staff, progress. They visit the patients sometimes, not always. And when they do, it usually is a pop in and say hi and leave. That's about it. Or, sometimes they'll even ask, how are you feeling? But they really don't, they don't have that time. Unless there's, of course, a problem with the patient, then they'll spend a lot more time with them. So we have a process here. The doctors come in and they want to know exactly what's been done with the patient, exactly if there are any problems with the patient, if there have been changes in the patient's condition, etc. So what you're going to do is, you remember the SOAP notes? Subjective, objective, assessment, and plan. Okay. So basically, you're going to use that sort of format. You're going to look and do an assessment of the patient. You're going to look at the subjective, which is what the patient says, okay, how the patient feels. Objective, what we can measure. In other words, the difference between signs and symptoms. Okay. Objective is what we can measure, find, calculate, whatever, from hard, objective data. Okay. So, and then we want to go through an assessment of the patient. Basically, the assessment is what's the issue with the patient, what's the disease, what's the expected course of the disease, et cetera, and then the plan. How are we going to treat this patient? And that plan can include not just drugs. It could be various forms of therapy, respiratory therapy, physical therapy, maybe occupational therapy, speech therapy may be a problem in some cases. So, the plan includes the global way we're going to handle the patient, not just we're going to give them a drug and hope they get better. Okay. And any follow-up information. Okay. So one of the things that's written down here on this is that medical shorthand and abbreviations are not appropriate in the final portion. The pharmacological approach in any form of physiology and your thought process that goes into this. Remember that hospitals are getting away from using abbreviations in medical records. And the reason is that there is a list. I mean, the list of medical terminology, of course, is very long. But medical abbreviations are often multiple. For instance, if you saw the abbreviation MS in a patient record, does that mean that they have multiple sclerosis? Does that mean they're taking morphine sulfate? Does that mean they're being given magnesium sulfate? So hospitals, these are abbreviations that are on the list of never use, always use the term. Remembering that list and the fact that has complicated things, and many hospitals now have decided to do away totally with medical abbreviations in the record. Does that mean that they never creep in? Of course not. I mean, you look at written records that doctors have, and you may see things like BP. Well, BP basically means blood pressure. Okay, that's fine. HR almost always means heart rate. But you look in, I remember the first time I looked at a medical record, and I was looking at a medical record of a family member, so I was not with permission, so I was not in violation of HIPAA here, and I saw the abbreviation SOB. It was about my father. Now, I know my father can be definitely an SOB at times, but it can be a bit realized short of breath. So we try to, we have some things that we know that we don't want to use. So rather than try to remember this rather lengthy list, we've done away with that in hospital records. That does not mean that doctors don't use them, especially when they're doing quick notes. But it does mean that for the permanent record, we want it to be quite a bit different. Okay, so let's take a look. So that's the assignment itself. So the question now is, what are your choices? And let's go take a look at that particular example, LRA cases. You have 4 cases. One, and each of them is a somewhat of a different disease process and bodily system affected. So what I'd like you to do right now is let's make a choice. We've got two ways of doing this. You can make a choice. There's only three of you, so I'm perfectly happy with that. But I want everybody to do a different case. And I will actually post something in here that lists the cases you've chosen. So take a look at that list. We've got a sexually transmitted disease, respiratory disease, genitourinary disease, and a case that is kind of a mixed bag. So the last one. Pardon? It's in the course home, right under the LRA assignment document that describes the assignment. You'll see LRA cases. So who wants to make the first choice?
It is.
Pardon?
Sorry, we have the list.
Yeah, it's called, it's the in course home, you'll see LRA cases. It's there. Genitourinary. STD, okay. Okay, GU, okay. Sarai, respiratory or the sort of mixed bag case. Pardon? You want to? Okay. Well, you can read the description. In fact, why don't you go ahead and open that case for each of you and read the description. See what you're getting into.
I'll do the respiratory.
Respiratory, okay. Done, okay. So I'd read the case a couple of times, get to know that patient, and understand what's going on with that patient. And then start doing your research as to what the potential diagnosis could be and an appropriate plan of action for that patient, okay? So that will be due on Sunday night, the 25th of March. Okay. Now that sounds like a ways in the future, but we all know that the time flies, especially when we think we have lots of it. you'll note that in this, in your scenarios, there are a lot of medical abbreviations. If you don't know what an abbreviation means, find out, because the information here, all of it is important. Okay. Okay.
Well, mine usually disappears. They say like take a hard but do it. Beating him with the bag. Like hurts though. I tried, I did it really hard. That's the only disadvantage. Yeah, right. It just hurts. Break your wrist. What'd you do? I've never broken the bone either. I broke my wrist. I was trying okay.
Okay. Let's talk about some principles of pharmacology and kinetics and pharmacokinetics, and just basically reiterate the things that we've already discussed in Pharmacy 208. First off, pharmacy and pharmacology really started with natural plants. Back in the ancient times, and all the way up to the Middle Ages, essentially all of our pharmacological agents were derived from plants, animals, or mineral sources. And the plant-based materials are still being investigated. There's a whole field called ethnobotany, which basically is studying the plant cures that are used by so-called primitive tribes and primitive groups around the world. The whole science is based on the fact that our early were derived. A good examples are things like aspirin, which actually is a derivative of something that isolated from quite a few societies from the ancient Greek on have used this as a way of reducing fever, inflammation. The problem is it's too nasty. The material salicylic acid. And so in the 1870s in Germany, a pharmacologist chemist working for the Bayer Corporation was looking for something that could help his father recover or deal with his very extreme and the product that was being used was this willow bark product, salicylic acid. And it gave his father ulcers by eroding the stomach. Couldn't eat food, prevent it. It was just that nasty product. And so he started playing as a chemist. He started playing with making derivatives of salicylic acid, and he finally came up with one, acetyl salicylic, that was just as effective and didn't have the same level of chemicals. In other words, you could take food and prevent problems with the cup. Well, this is aspirin. And aspirin quickly became the largest selling drug in the world. It is still one of the largest selling drugs. And Hoffman, by doing that, essentially created the modern pharmaceutical, or the idea of the modern pharmaceutical, which was to synthesize drugs that are not found in the environment. Now, a lot of it was based on natural products, and so we started looking at virtually all of the different kinds of products that are available, including deadly nightshade, the source of belladonna. Belladonna is used commonly now by ophthalmologists who want to dilate your pupils. The derivative that we use to do that was originally from the belladonna. It's called belladonna because the Romans used to use it, and they put it into women's to make them dilate because they thought that made their eyes more beautiful. Belladonna, beautiful lady, is where that comes from. So another thing is that we have a whole class of drugs that are used surgically. When you are in surgery, they have to relax your muscles. And the reason they do that is, of course, if you stick a piece of cold steel into somebody, they're going to cancer. So what we do is relax those skeletal muscles for several purposes. One is to make it possible to actually cut, but the other is to make it possible to actually intubate a patient, put a tube down their throat in order to hook them up to a breathing apparatus. Because when you shut off their skeletal muscles, they also can't breathe. And this is all based on various toxins, poison toad toxin, poison plant toxins that are used around the world for hunting purposes. People would dip their arrows into these things and shoot an animal, and then they just wait for it to fall because it would be paralyzed, and then they'd go harvest it or get it. So the problem, of course, is that many of them do not actually cause anesthesia. You can still feel the pain even though you can't react. So it has led to a whole line of products being developed. There are a whole series of products for relaxing muscles and inducing anesthesia on a patient. So these all came from understanding that we have to have, that we have to have, that we have these products in the natural environment that are very effective, and we can, in various ways, make them more effective and form the basis of much of what goes on in the pharmaceutical industry today. When we're dealing with drugs, there's lots of considerations we have to make. One is when we are looking at drugs, we're looking at several things. Looking at how fast the drug acts, the speed with which the effect comes out. We want to know how fast is the action of the drug. We want to know the intensity. In other words, how well does it work? For instance, aspirin is a great drug for pain relief, mild pain, but it doesn't do you a whole lot of good if you have intense pain. So we look for more potent pain relievers. We'll talk about pain. Pain is a whole area that we'll spend some time on. And then, how long does it last? The duration. Different drugs will last different amounts of time. And the effects of that duration really are where we come into the whole issue of pharmacokinetics. Because this defines how fast, how intense, and how long. You'll note that some drugs you take once a day, some drugs you take twice, 3, 4 times a day. We don't generally like drugs that you have to take more than about 4 times a day for one major reason, and that is that patients don't comply. Compliance is an issue with drugs, and that's why we developed a number of years ago various formulations that were long-acting. Remember, there are drug forms for our oral drugs include long-acting forms where the drug is released slowly from the drug matrix. And that's because many drugs have to be taken far too often. Actually, ideally, you would take a drug and immediately get an effect. It would be at the intensity you need, and you take it once a day. Preferably at a time when you can expect the patient to take it, like as soon as they get up in the morning or just before they go to bed at night. Okay. However, that is not the world of reality. The world of reality is that sometimes you have to take drugs more than once a day. If you remember from when your kids had, when your kids were young and you were giving them amoxicillin, it was 3 times a day. And that's because the drug has what we call a half-life. Half-life of a drug is the amount of time that it takes for 1/2 of the absorbed dose to disappear from plasma. For some drugs, the half-life is literally a couple of hours. For some drugs, the half-life can be 12 or more hours. So we adjust our dosing schedule to the half-life. There are other drugs that seem to stick around forever. Years ago, we had a friend down in Arvada who had breast cancer when she was younger. And she would go in once a year for a dose of once a year for a dose of a drug that was helping keep her breast cancer at bay. That's a pretty long half-life. Okay. And the fact that it was working was good for whom? And what do you think?
Well, I don't remember when I was smaller, but they would give it to me when I was
Well, in some cases, the drugs will have some side effects that are better initially, that are better if you're asleep. Things like dizziness, things like mild nausea. And sometimes it's an absorption issue. People that take magnesium supplements, for instance, which quite a few people take, the data suggests that, and we use it to actually strengthen bones. It's one of the components of the whole osteogenesis process and one of the controlling factors. So we use it for that purpose. If it's for that purpose, then what we want to do is it's slowly absorbed. You take one a day. So it's slowly absorbed. And so what they want to do before you start weight bearing on your bones, it's also used, it also helps control muscle. So before you start actually using the muscles and before you start weight bearing on the bones, we like to have it absorbed. And so you take it at night before you go to bed. And then by morning, you've absorbed the dose and it's in place. So there's lots of reasons for that. And it all depends on the drug.
Well, I'm not sure if it was I
Mhm.
remember when I was after I had my mother, they kept coming in the middle of the night, just like wake me up and give me like more medicine and stuff like that. And I was like, dude, why right now? I'm trying to sleep. Like my daughter's sleeping. Like I'm trying to sleep too. And she's gonna be awake. I never got. And I'm like, I don't know. I got a C-section, and they just kept giving me morphine and morphine and morphine, and I don't know. I remember my daughter being in the incubator because she couldn't breathe on her own when she first was born.
Right.
And then when she ended up like her lungs were okay and stuff. And then they ended up bringing her to the room and they gave her to me. And like, I felt like I was going to drop her. I was like, I was not there.
Right.
And it sucked because, you know, like the first moment.
That's when you bond.
At night, just to give me
Well, they do that after vaginal thing too, because you're so doped up on fentanyl and the spinal tap,
Uh-huh.
and then they lay the baby on you, and you're like, I know, like,
Why do they do that? The problem, to be honest, is that often it's done for the convenience of the staff rather than the convenience. You do have the right to refuse.
I don't think
Remember,
it would've done
that's
it
part of your
without
patient
the
rights.
Right.
Yeah, they don't like it when you say no, but you have the right to say no. And you have the right to dictate to them even how they dose. Remember I was talking about the difference between a fast bolus and a slow bolus drug? Well, fast bolus is often very painful because you're putting a foreign substance into a blood vessel which doesn't like foreign substance.
Well, I remember that day in the morning. I knew like they will give you a lot of morphine and you will not be all there. So I remember like I brought in a letter, like an handwritten letter saying that my mom could if I didn't want like drugs or whatever, because I was already 18. But if like I'm 18 and I'm in bed, like if they ask me something, I'm not gonna know what to say. You know, I'm not there or whatever. So like when my mom seen that I couldn't even hold her, like she dipped out, like we need to like turn it down a bit. So then she like
Really?
came in and she's not with the kids or whatever.
Yeah, part of the problem, of course, with things like narcotics is that everybody reacts differently. Some people are more sensitive, some people are less sensitive. Some people, like I won't take them. I have to be in pretty awful pain. And for me, the worst pain I ever felt. I mean, I've had surgery and a couple of times, and that was nothing compared to the tooth extraction. That was the worst pain for me. Of course, women going through childbirth, that's pain that we guys can't ever understand because we've never been there, and we can't go there.
Yeah, I wouldn't have been able to
Yeah, but some people just won't take them, and you know, painkillers are really something to help you relax. When you're in pain, you're tense, and that makes the pain worse. Especially if we're talking about a C-section or vaginal delivery, or you get tensed up, and it just makes it worse. Especially if you got an episiotomy, then it just gets worse. And so the object of painkillers, from my standpoint, is to take enough of an edge off the pain that you can relax and let the body heal. Which, by the way, even for most things, will be fairly quick. And you'll stop feeling the pain. However, different people, and there are different reasons. I mean, people that have pain that's related to like back injuries or the pressure on the spinal column, that pain is almost impossible to deal with because we can't get the drugs to the site. The only way to do that is to literally inject it into the spinal column, and that's pretty simple, as you probably remember from childbirth. That can be pretty nasty.
Yeah.
Yeah, the epidural. That's direct into the spinal column, what we call intrathecal.
It really messed up. It didn't mess up my back. My son messed up my back. I think he cracked my. I still have pain in my tailbone when I sit for a long time.
Well, that's not unusual. I mean, I've never had a baby, but I have the same issue. I sit for a long time, my tailbone, I have to get up, I have to walk because it just hurts like.
He did it when he was like, when I was 8 months pregnant and he was breech. Yeah, he flipped. And then I couldn't sit, I couldn't lay down for like weeks. And it finally got to the point where I got used to how painful it was. I was able to push him.
Yeah.
It was so bad.
Yeah. Well, that's where, that's the rare times I would take, ibuprofen, is just to take the edge off it.
They gave me lidocaine, and that didn't even.
I think that's more placebo. To tell you the truth. For things like that. Yeah. We're not, this is not. Okay. Here's where our pharmacokinetics comes in. The duration, remember how fast depends on the dosage form. An IV drug essentially has immediate effect. Number of years ago, my wife got broadsided at an intersection by a guy running a red light at 35 miles. Totaled our car. It ended her career as a physical therapist, basically, because she broke her hand. Well, you can't do PT with a broken hand. That just doesn't work. So, but we were in the hospital. She called me, and I, of course, left work and went down to the hospital. And we're sitting there in the ER, and they wanted to give her fentanyl.
I got that.
Yeah. I wanted to give her some fentanyl. And so she asked me if she should take it. And I said, well, let's take a look at the dose. You know, my dose is an appropriate dose. And I said, it'll probably help. And so they put in the fentanyl, and she said she could feel it. You know, I've never had the stuff that I'm aware of.
It makes you feel like you're out of it for 15 minutes.
Yeah, but she could feel it spreading from where the injection site was, just through her
Feels
hand.
really hot.
Yeah.
it does.
She could feel it spreading through her hand and then into the rest of her body. And she definitely was out of it. It was a good thing I was there to try. She was definitely out of it.
Yeah, because you can't even, it's
Yeah.
like being drunk, you can't sit up.
Yeah, yeah, it was, you know, it was
Yeah,
really
like-
kind of interesting. But that was an immediate effect because it was an IV dose. Okay, so that, and then other injectable routes like IM and sub-Q take about 10 minutes because you've got to absorb the drug out of the muscle or out of the adipose tissue. Oral doses generally take around a half an hour before you start actually getting drug measurable, getting drug into your plasma. So the pharmacokinetic profile, that's the release side. You know, effectively, as soon as the drug is injected intravenously, it's released. And it just takes a while. It takes about 2 minutes to distribute throughout the body. So then our pharmacokinetic profile. We have absorption, remember? Distribution. Metabolism. And excretion. Also known as elimination. So the absorption, really we're talking about from whatever tissues the drug has gone into. Obviously, absorption is virtually immediate with an IV drug. Distribution, it is a little bit longer. You have to absorb it out of that little ball of liquid that you put into the muscle or into the adipose tissue, the subcutaneous space. Or if it goes into the stomach, it has to be after the dosage form breaks down in the stomach, which is obviously a lot faster for drugs that are in liquid form because you don't have to break up a tablet or dissolve a capsule. Takes a little bit longer, and then it's absorbed through the stomach and the small bowel. And where does it go first? The liver. So in oral drugs, anything that's absorbed through the GI, it goes to the liver first, and then it starts this process of metabolism early. This is called the first pass effect. Remember that phrase, first pass effect? The drug goes to the liver. Some of it's metabolized, anywhere from 10 to 80% metabolized in the liver on this first round. That's one of the reasons, since that oral drugs are much higher dose than injectable drugs very often, because the liver will metabolize a great deal of that first round of drug as it goes in there. Distribution, getting to the body. It goes to, most drugs are just uniformly distributed throughout the body through the plasma. And we measure this by actually measuring drug. And if you look at this pharmacological principles diagram that I just gave you, you'll see that we have a plasma level on how the drug is. We have a plasma level that rises over time up to maximum, with maximum concentration at a specific time, which we call Tmax. which is the time it takes to reach maximum plasma concentration. And then we lose half of the drug. So basically half of that distance from the bottom axis to the top of the curve. When we lose half of that concentration, that's the plasma half. Okay. So that all determines our dose, that concentration curve versus time is dependent on dose, and it also instructs us as to how often the drug has to be administered. If we look at a plasma concentration over time curve, ideally, we would maintain a therapeutic level that was constant. In fact, since we have this peak plasma, etc., and we have changes in concentration over time, we dose so that the average concentration is where we need it. And that's all determined in clinical trials. We have a pretty good idea from animal models, because when we're developing drugs, the first thing we put them into is mice and rats. And occasionally another animal, dogs. We use a lot of dogs in the pharmaceutical industry as well. Rarely, because of the difficulties of working with them, will we use any primates. Primates are very difficult to work with. There are too many rules to make them common animals, and quite frankly, a lot of people messing with primates. And on top of that, they can be awful. I remember when I was in the Army, chimpanzees. This is before they really we had one chimpanzee to work with. You go into that place, and they're strong. And so I remember we had a guy, great big guy, looked like he could have been the center of the gigantic. He stood about 6'3", probably weighed 300. Strong. And this monkey, he went to pull this monkey out, and the monkey bit him. And he grabbed the monkey's feet and the monkey's arms, stretched him out, and bit a chunk of flesh out of the monkey's back himself. That monkey never touched him again. He became the bigger monkey. And I thought, I didn't have so what we want to do with our absorption is have a dosing schedule that gives us roughly a steady plasma at a therapeutic level. And that therapeutic level is in our clinical trials. Okay. And so the absorption, the distribution phase is when the drug is going through the body, and some drugs will preferentially localize in certain kinds of tissues. We have drugs that are water soluble. We have drugs that are not water soluble, and they're more fat soluble. So they will end up localizing in different areas, but they pretty much distribute throughout the body. So that's one of the issues with drugs. They don't necessarily go only where we want them to. That's why they have side effects, because they can affect other tissues as well. So Metabolism, remember metabolism is modifying the drug to get rid of it. The body does not like foreign substances, and drugs are considered. So the body has a number of ways of dealing with foreign substances. One of the nastiest ways the body has is through an allergic reaction. That's why that's why you go into the doctor's office. Do you have any drug allergies? So you see in a medical record, no known drug allergy or allergic to, many of us are allergic to things like penicillin, which is a microorganism derived drug. There are many drugs out there, and anyone can be allergic to any of them. All of those drugs have people that are allergic. So it's one of the most common side effects that we look for. That's why you have the instruction if you have a hard time breathing, or if you start breaking out in hives or rashes when you're taking a drug, stop taking it, call your doctor immediately, because we don't want to see you go into real problems. Drugs are also toxic, all of them. There is no such thing as a safe drug. Even drugs that we can buy over the counter, aspirin, cough medicine, they all have the potential for side effects. Most of us have no adverse events associated, but occasionally somebody will. So there is no such thing as a safe drug. We always have to be on the lookout for problems. And of course, any drug can be abused. So in the drug field, not only are we looking at concentration over time, but we're looking at a therapeutic level. Okay? So let's just say we have a therapeutic level. This is the concentration at which the drug has its maximum. When we're developing drugs, we are trying to determine what that is. And the way we determine that is in a series of studies, we increase the dose of the drug. And what we find is that at one point, we get no additional effect, a maximum effect, probably because we've saturated all of the receptors or whatever. But we reach a point at which additional drug doesn't have additional therapeutic value. And that's the therapeutic dose. Now, at the same time, we're interested in knowing what the toxic dose is. How do we determine that? Well, in our phase 1 clinical trial, remember, the purpose of that study is safety. What we do is we keep giving our healthy volunteers increasing amounts of drug until something happens. And the something, hopefully, will only be, we're looking at blood chemistries, and all of a sudden there's a change in liver function, which means the liver is being affected by the drug. Or some kidney function is affected. We start to see an effect that would indicate that the drug is having an adverse effect on the patient. At that point, we define that as our toxic level, and we click the drug level. So what we want is we want this space here to be as wide as possible. The wider it is, the safer the drug. We call it the margin of safety. Do we have drugs that the margin of, nowadays, most of our drugs have a pretty wide margin. But we do have drugs that are commonly used that have a very narrow margin. Drugs like digoxin. The difference between an effective dose and a toxic dose is relatively small. But digoxin has been around and being used for 300 years. And we understand it. Cardiologists love it for regulation of heartbeat and heart function. Cardiologists love it because they've used it for years. And it is dirt cheap compared to most drugs. Okay, so it's 10:30. So let's take a second break, and we'll come back and talk about other things. Couple of things to think about in terms of textbooks. We're modifying the way our classes are structured, and we may find yourself online for a while. Well, going forward, if you prefer a hard copy textbook, some of us old school guys who don't even like e-reading. You can ask for a hard copy. How long they'll be available. But for a lot of reasons, we're going that. Okay. So we've talked about distribution and therapeutic levels. The next phase of our diagram here is metabolism. Metabolism is, as I say, the body doesn't like drugs. They're not supposed to be there. The body knows what is supposed to be, but drugs need to be dealt with. They're dealt mainly in the liver has a set of enzymes which are given the designation cytochrome P450. Now, the origin of that term is not terribly important. It's a designation for a system of enzymes in the body that metabolize drugs. And different drugs are metabolized by different parts of that enzyme system. And those are based on the ability of the enzymes to either add something to a drug to make it more amenable for elimination, or take something off a drug to make it more amenable. Now, drugs that are water soluble are fairly rapidly metabolized. Drugs that are not water soluble are more fat soluble. They get stored in fatty tissues and released slowly over time. And so they don't get destroyed nearly as fast. That's why some drugs, like drugs that are active in the CNS, many of those are fat soluble drugs because the brain is a big fatty mass, really, are more slowly metabolized, which is why if you're taking many of the antidepressant drugs and psychotic drugs that we have, and I hope you're not, but if you are, if they decide to change drugs, they need to give you a lengthy washout period so that your body can clear the old drug out before they start getting the new drug back in, because these drugs often interact very poorly and very dangerously. So, but the cytochrome P450 system is as I say, is a set of enzymes that metabolize drugs for the next phase. One of the interactions of drugs that we deal with, and one of the things that we look at when we're looking at those interactions is what part of the cytochrome P450 system is involved in the metabolism of the drug. Because interactions can occur when you have two drugs competing for that system, or the system competing for the two drugs. When you have two drugs, then the system is not going to be efficient at removing them as if they were just the one. So if it's the same part of cytochrome P450 that's being affected, then it affects metabolism of drugs. If you look at some drug labels, it will tell you, do not take grapefruit or drink grapefruit juice. Do not eat grapefruit or drink grapefruit juice while taking the drug. And that's because that drug is metabolized by that same portion, that same part of the P450 system as the grapefruit. And the grapefruit will then saturate the system, and we can build up toxic levels of the drug because it's not being metabolized, because the system is busy. Now, that doesn't mean that you can't ever eat a slice of grapefruit or drink a glass of grapefruit juice. It's just that it needs to be not part of the diet. One of the most common drugs that we have right now that people use is warfarin, which is the oral anticoagulant drug that's taken by a lot of people, especially anyone who has some sort of foreign substance implanted in their body, whether it be a steel rod, a bone, or a pacemaker, or an implanted insulin pump. We put patients on these on anticoagulants because the body's mechanism for getting rid of a foreign object, so drug, is to clot, surround it by clotting material in order to isolate. And then those clots then peel off and people have strokes, heart attacks, etc. So we give them these doses of anticoagulants, which have to be very carefully watched, to prevent that from happening. So what we don't want if they're taking like warfarin, we don't want them eating grapefruit because warfarin actually is a drug, another one of those drugs with a narrow therapeutic window, therapeutic margin, safety margin. So we do that. That's the reason. That's some of the reason for some of the drug interactions that we see is because of the metabolism issue that gets in the way. There is a term that we use called bioavailability. Bioavailability is the fraction of a drug that actually gets into plasma. So the bioavailability of an injectable drug is often essentially 100% because it's all going into plasma. You're putting it directly in the system. You're putting it in plasma. We use bioavailability as a measure of proving the efficacy and safety of generic versions. Remember, we talked about, at least at some point, we talked about the fact that it takes years and potentially hundreds of millions of dollars to develop a drug. And for the first time. But the generics are copies of the drug that have already been proven to be safe by virtue of the fact that they've been. So the generic industry does not need to spend hundreds of millions of dollars developing a drug. What they do is they will develop their formulation of the drug, which quite often is exactly the same as the original. We have the capacity now to do chemical analysis But all we have to do in the is do our version with the manufacturer's original version, exactly the bioavailability. The fraction of the drug ends up in plasma as the originated drug. Most of our drugs are oral because those are the cheapest drugs to make and the easiest. So we do that. So that bioavailability is a critical factor. Okay. So what has okay. All right, let's move on to a couple of other. There are. We talked about the issue of how quickly, how what is the intensity of the drug and how long does it last. But we're also interested in the efficacy of the drug. Efficacy is defined as the effect that the drug has, presumably positive therapeutic effect the drug has. If it's not positive, then it's toxicity. But the efficacy is what the drug has the desired action. Now, we can have two different drugs which have the same, say, mechanism of action. If we take a look at, for instance, blood pressure medication, people will take blood pressure to lower their blood pressure by some amount that the targeting. Let's just say they want to lower the blood pressure by 30 points systolic. Okay. So we often will talk about a drug that, say, 10 milligrams of A will lower points, or 20 milligrams of B will lower points. And we often say that means A has a greater efficacy. That drug will lower the blood pressure. But it's a little more complicated. It's not a bad drug. The measures of potency are how much drug is and the again, direct comparisons of drugs are difficult. We talk about drugs. If we look at a drug for regular we have Jackson is common drug. That drug is very small amount. We get to channel blockers and so forth, and their dose in milligrams. So, what the toxin is a much more potent drug. With potency, often though, we have associated toxicity. So we want to be clear and efficacy are terms that we use rather than ones that drugs that have a different dosing are often considered better than drugs that have more doses. Case in point, when Tagamet, the dosing regimen was a very effective drug. It was a $1 million drug that So there's been a few years ago. But it was the first drug that was developed by Smith Farm. Black Dog developed a chemically related drug. And they compared clinically the results of the clinical trial, which basically overall were identical with Samedi, and they were worried that their drug could not compete with Samedi, basically the same thing. And one of their marketing people said, well, wait a minute. If I look at this, I'm seeing a drug that can be dosed twice a day. In fact, it can be dosed twice a day instead of 3 times a day. And after some instruments, I know that they were the drug company across the street. And so one of the guys was telling me this story. He almost got me. And then the marketing people said, well, we can sell this 3 times a day. And we already knew that the fewer doses a day had better performance. Well, Zantac immediately was marketed. And within a couple of years, it's gone higher than Cimetidine and Vitamin because. So the issue of efficacy is a complex thing. It's not quite as simple as Zantac makes it sound because there are many chemical and physiological reasons that efficacy of 2 different drugs doing the same thing do not be a good measure of it. The only thing about drugs that you can make less of is they are theoretically cheaper to make, and so your profit margin might be higher as a drug company. Now, they might be cheaper to make, and they might not. But there are lots and lots of examples of drugs that are doing very, very well based on dosing studies. Another different blood pressure medication, the first one was a drug called propranolol, marketed as Inderal years ago. It was, I think, dosed either 2 or 3 times a day, and was a huge seller. It was a very important drug. It was also relatively safe, I mean, for a drug. A number of years later, the drug atenolol came out, which is marketed as Atenolol. And atenolol is a once-a-day drug, not exactly the same as and essentially the same toxicity as propranolol. But 1 dose a day made a big difference, and a preferred drug. Again, ideally, when you take drugs once a day, people are more likely to maintain the regimen. Drug interactions. Drugs, remember we talked about this. Drugs interact. We looked at drugs in other classes. One of the things we looked at was food and other stuff. Well, if there's only one food interaction to look at for drugs that are used or metabolized by some families but drug interactions can take the form of take several forms. One form is called addiction, meaning that the drugs basically don't change each other's activity. At the same time, each drug has the same effect as by itself. Okay, so there's no real interaction there. Then there's the process of synergism. Synergism is where the drugs actually enhance each other. Okay, and that enhancement can be positive or negative. It can be an example of a negative would drinking alcohol and drugs can kill you. That's a pretty nasty synergistic
Videos on Facebook. We put it in the, like that drink lean or whatever.
effect.
it is,
Yeah,
The cold medicine, Sprite, and then they put this in like.
they're playing with fire. And a lot of times we call the people that do that corpses,
Yeah.
you know. And you know, I don't understand that name. It doesn't make sense to me that we would try to do something silly like that. People do. It's just unbelievable to me what people will do. And another one is called propitiation, and that's when one drug enhances another, but it itself has no change. Okay. Example that's given here is vitamin D plus calcium. Vitamin D and calcium are both supplements. They're both necessary. Vitamin D, calcium obviously is part of the oxygenic process, but calcium also is a critically important cation, electrolyte in electrical. So calcium is a very critical material. Vitamin D just enables the uptake of calcium. Calcium is enough. I mean, you know, people that take calcium supplements and don't have sufficient vitamin D are basically wasting their money. Calcium doesn't just readily absorb in a great. But vitamin D enables this process. So that's why vitamin D and calcium and magnesium and zinc are all required for proper bone matrix. All of these things contribute to that process. But vitamin D enables the absorption of calcium, which is good because it helps with vitamin D itself. Obviously, you still want to have vitamin D, spend a lot of time because the sun helps synthesize vitamin D in the body. If you don't have it, if you're like most of us anymore, we stay indoors most of the time, and instead of sunlight, we got these things. We need vitamin D in order to properly lay down bone. It's why we encourage people that have the precursor to osteomalacia. We urge them to take big size doses of vitamin D so they can maintain their bones. Then there's finally something called antagonism. That's the basis now for wanting to, I don't know if you followed this at all, but the discussion and controversy really over keeping Narcan available on college campuses to overcome opioid overdose, which are really killing a lot of people. Narcan cancels out the opioid. You take Narcan on its own, and you can get high. But if you have an overdose of morphine or heroin, Narcan can rescue you. They cancel it out. Other one is, amazingly enough, aspirin plus ibuprofen. They cancel each other out. So again, you're wasting your money if you put them both. So that's a couple of things. Yes.
So I heard that if you take an antibiotic, like birth control things not working effectively. Why is that?
There again, it depends on it's not all birth control, okay? It depends on, again, there's the cytochrome P450 system because the antibiotic and the birth control, and it could be that they were both affected by the same enzyme subgroup in the P450 system. But I've heard that too. I don't think I've ever met anyone who claims that she got pregnant while taking an antibiotic, pregnant on her birth control while taking an antibiotic. So I don't know, you know, but it might be something we want to look at, just to see what the connection is. I just finished teaching a statistics class here, and one of the things we talk about is correlation. Correlations are when people say, okay, this happened, and this happened, so they must be related. And they might not be. But I have heard that. And I think that they've gotten improvement in various forms of that should have improved that. But I'm not sure. I probably might want to look into that to see childbearing age varies. Okay. So we have another problem that occur with drugs, and that's the problem of patients taking drugs long term often get to the point where the drug's activity is decreased to the drug, and they require more. This is one of the issues with painkillers. People do become tolerant. One of the reasons that even the OTC painkillers, like ibuprofen, Tylenol, you should take very sparingly, because we do develop it. One of the reasons they're complicated, some of it has to do with ramping up this P450 system. And so it becomes more efficient. If you're taking a drug, the body is seeing more of it. So what does it do? It makes more of that section of the P450 enzyme. And so you then be able to metabolize more drug more quickly. So that's part of it. Another part of it is that sometimes the body just stops. And so we have to be aware that happens. Now, what do we do in that? Well, one thing to do is look for an alternative that may be differently metabolized on a different subset of and a drug. This is one reason that drugs actually stop working, other than non-compliance. That's one of the biggest issues. One of the first, especially for drugs when patients say that the drug isn't working, are they being compliant? Many patients will become non-compliant. And then we'll tell the doctor. they'll just stop taking the drug. And then not only will they stop taking it, they'll lie to the doctor. So it's very, very difficult. Then there's dependence. Dependence is a little different than dependence has a large psychological. There can be some physical narcotics are a prime example of drugs that are physical dependence. We refer to it as physical dependence, as well as the psychological. People will not be able to face life. They can't function without taking a drug. We see this especially with drugs like the anxiolytics, the Valium, Librium, etc. We really did not understand that they could generate the psychological dependence. And it became a problem in the 60s when we started seeing this. A number of years ago, this was about exactly the topic that was called Withdrawal. And withdrawal was a nickname for these pills that people were taking. And it was set in the valley, the LA basin. And it was about a group of housewives who were taking pills and become those turned into a holiday. Then likely, and after that, the term withdrawal is used. Withdrawal is a process where the body has become dependent on drugs and we suddenly stop taking it. We see it with narcotics, the sweats, the tremors, the pain, etc. With with patients who are getting who just go cold. That's why when we have a patient who has become psychologically or physically dependent on drugs, we don't want to just say stop taking it because they may go through withdrawal, which makes it more likely to take that kind of drug. That's why the treatment for reducing dependence on drugs involve gradual tapering off the dose to the point where you can start to stop the drug, but you have the body adjusting to lower and lower drugs along the way. So we have a lot of many drugs create this dependence, and we have to be careful when we're dealing with patients that we want. Finally, one of the last factors that affects drug activity is the patient himself. Hey, Cody, come in.
Hey.
You want to introduce yourself?
All right. I'm Cody Smith. I'm the new IT guy. I'm replacing Anthony. Got a new gig going on at Denver Framework. So if you have any technical issues, just look me up. I'll be around campus. That is it.
All right. Great. Welcome on board. I'm your new role on board.
New role. From March 6th,
Great. Thank you very much. Age. We all know that we've been told repeatedly that children and the elderly have different responses to drugs. A lot of that has to do with the fact that in children, the P450 system is not really well developed. It's something that is developed as liver challenged by drugs, by food, by all the things that it metabolites. not developed that system. So when they're young, they're more susceptible to drugs. Which is why if we are giving a drug that's mainly for adults to a child, a baby, we reduce the dose significantly. And it's not just because they're smaller people, which they are. It's that their bodies just can't handle it. The elderly, however, the people of 50, 60 are starting to decline in its efficiency. And so we find that the elderly often have than when they were, say, in their 40s. So again, it's a case of looking at every patient and making some judgments about how to treat them. Fortunately, there's a lot of information now, many drugs, new drugs. We already have information about pediatric dosing, and a lot of times we'll have dosing. Why? Well, we're going to have 75 million in not too many years. By the middle of the next decade, in this country, at least 75 million. And the older we get, the less we have over time. We monitor the how my mother-in-law is doing with her pharmacy drugs, heart failure, COPD, a lot of things. She's managed to live on. And we're fortunate, and she's double. She doesn't seem to have any problems because we know that she's losing the ability of the body to handle these drugs. So we keep a good level of that. Pregnancy, obviously, half a smidgen over of the population could become pregnant or have become pregnant. Pregnancy is an interesting place to be, in that we have a second person that we're supporting physiologically for those 9 months. And the drugs, many of them will cross the placental barrier and go into the fetus. When we have no general studies on what that means. We have some specific studies. We know that some drugs cause birth defects because they get in. And nowadays, we test all of our drugs for the potential for birth defects. Yeah, probably better off. Tylenol has liver effects. I would not want Tylenol if I was pregnant. Yeah, and I think we have enough experience with Tylenol to have a body of evidence fairly safe. I don't know about ibuprofen. Yeah, and again, anything in moderation. You wouldn't want to for 9 months. Without a little bit of liver in that child is going to be affected. Another one is back in the 1960s or late 1950s, a drug that was a potent anti-nausea, and it was developed strictly for. Well, what is the biggest source of nausea in our society? pregnancy. Virtually everyone I know has been through morning. No, you're lucky. You're lucky. Morning sickness really killed me because she got dehydrated. She actually lost 20 pounds. And she was about Berenice's size. Right, 23 pounds off you would. No, it would look pretty bad. It would look Um, but, so I can understand what happened. So this drug was, without having ever been experimented, it was used extensively. Morning sickness. The problem was the babies that were born were horribly physically changed. They would have no arms, no legs, or they had like slipper arms, or these kids had no mental problems outside their normal brain. So it was only physical. And it turned out that this drug was causing it. The end result was that, as usual, time we developed it. It's easy to say, well, we should have tested it. No, we didn't do things that way. So now every drug is tested for the potential for virtue. Usually do that tested initially in rabbits. We will do tested in rabbits and we will, just feed them and give them the drug and see what happens to their uptake. And we usually test often for whatever reason. So now we test these things. And so every drug now has pregnancy. Pregnancy category A means that we have sufficient clinical evidence for the drug safety while the patient is pregnant. Okay? So we know it has no effect on the fetus. All the way up to pregnancy category X, which is we have proof of human teratogenicity or infertility. So we have a gray area where we have some studies that we found that animals can have birth defects, but there's no evidence in humans, or where we have animals that don't have birth defects, we still have no evidence. So this pregnancy category is and that is basically that unless it's pregnancy category A, then we don't want to, then we want to be sure that the drug is going to be for the patient. As an example of a very common set of drugs, we have some of the top selling drugs in the world over the last decade have been cholesterol lowering drugs, statins, and related compounds. All of those because why? Well, if you remember from AMP, cholesterol and long-chain fatty acids are required to be full. And if we interfere with that in a developing fetus, that's not good. You're going to have problems. So, pregnancy category, smoking and drinking causes problems as well. It raises, it initiates P450, so liver and kidney disease are issues. Liver, the liver for us is a metabolic organ, rather. The kidney is the main organ. Most of our drugs are treated through urine. So if we have a kidney impairment or liver impairment, the liver results in the excretion system, and drugs that are treated to the bile are sent out of the liver and then go into the colon. So we have two main routes of excretion, the colon and the urine. Finally, there are psychosocial issues. These don't necessarily interfere with the efficacy of drugs directly. They may interfere with the ability of the patient to buy the drug. They have no money, it's hard for them to get it. Or there may be, and this is a case, my heritage is Irish. And in Ireland, it is it's an embarrassment if you are taking drugs for depression or any of those things. And the reason is that it's a sin to be insane in Ireland. So they won't take the drug. Or they won't let the children take the drug. So there are some forces that the home life may actually prevent taking the drug. Plus, people that have bipolar disease, you go through a phase where you just pop on and funny and the life of the party, and then you crash and you're so depressed you get out of it. There's a whole the people that suffer from those diseases often won't take the drug because even though they hate the low, the high is so much fun that they don't want to lose that, so they won't take the drug. And so it is something that you need to be aware of in dealing with. Questions?
What is it? So the impact, they take away the.
Yeah, when you bipolar, it's the way the highs and the lows. It's sort of and the highs are so much fun. I had a sister passed away a year ago, who was bipolar. And when she was good, she was very, and she was fun and funny. But when she was on the down, and she was taking fights she didn't take a drug. The highs were so much fun. And the lows, she forgot about that. I don't like that one. That's another thing. Okay, let's take our last break. And we'll go in.
Is tramadol?
Tramadol?
Is that one of the drugs we can choose for? I'm very curious.
Yeah, I have those in everywhere. Like I have one in my car. I have so many at home.
Is it like
At work. No. It gets frozen though.
I just have a few at home. I'm not big on.
I do. When they have those sales at like Victoria's Secret or Bath and Body Works.
I do. I stock up, but I keep it for so long.
On Black Friday at Bath and Body Works, should I be like $3?
Okay, let's go ahead and get back to the class. I'd like to talk a little bit more about the and have you choose your topics so that you can, because this needs to be done by the end of this week. So if we go to the text, at the end, we have on page 550, we have a list of the top 200 brand name drugs. Now this, notice it's brand name drugs. If we were looking at every drug, we'd have a much different list. And the reason is that the FDA, treats every drug, every generic approval as a different drug. Okay? So you can have, this is why we have, if you look at a list of all approved drugs in the United States, between 7,000 and 8,000 drugs. And that's because of the definition of a drug. We generally think of all generics and originator drugs as the same thing, but remember, the FDA has to approve not only the drug itself, but also the manufacturing process that it's being manufactured. So if you have a drug that has dozens of different many of them, that's a dozen different drugs as far as the FDA. So this list leaves out they're generic. A few years ago, before Vicodin was classified as Schedule 2, Vicodin and its generic equivalents. There was something like 6 or 8 of those on the market, and between them they sold 150 a year. That's a lot of prescriptions. So now Vicodin is not really in the top drugs and the top 20 anymore, for the simple reason that when it gets switched to Schedule 2, we then limited the number of doses that we provide doses over a period of time. So that's for an individual. So we changed this list. We're going to use this list anyway. And what I would like you to do is, Sarahi has already chosen one drug off this list. She chose Tramadol. Adderall XR. Okay. Okay. Remember what the XR stands for? Extended release. Okay. So that's different than regular Adderall. So yeah, well, that's because that's what they've gone for. Regular Adderall had to be given weren't taking it. So it wasn't helping. So I'll be interested in seeing what okay.
Review.
Which one is that?
23.
Oh, Spiriva. Yeah, okay. All right, that's a respiratory drug. Okay. Great. So let's talk about what we're going to look at here. And it also has a grading rubric at the bottom. This is how you will be scored. Note that it does not have to be an APA paper. But I want you to be sure your grammar and spelling are correct, and that you use the proper format for your sentence. Get used to doing everything using the proper format. Note that these are brand name drugs. So if you're thinking that, you should check the manufacturer. But I will tell you another thing that happens is often companies will have their drugs manufactured either by a company subsidiary with the manufacturing or by a contract manufacturer to make sure you get that who's actually manufacturing the drug. Because you can anyone with an approved facility to manufacture the drug, and someone else buy it, put their own label on it, and sell it as though they manufacture. The only thing that is important from a regulatory standpoint is that facility. Okay. All right. So dosing schedule, where are you going to get that? Well, you can get it out of your pocket. What I would like you to do, besides a healthy adult age 35, is note whether there are different note that 35 to 50. That's a funny age group. Usually we're talking 18 to 55. So you may not find 35. So don't worry about it if you don't. Just repeat, give the information for the age groups that we actually have on the label. Pharmacokinetics is always a section on pharmacokinetics. The section on pharmacokinetics and hypocrisy is very, very slight, not a good thing. So you want to go to a different source, either one of those others for all of that should give you the pharmacokinetic material. If indeed some of that information is just for some reason isn't there. Quite frankly, some drugs we have no idea how they work. A good example is a drug that's often used for treating depression. Lithium has been used for many, many decades to treat depression. Nobody has a clue how it works. It's not a requirement. Most drug companies will spend a lot of time investigating how the drug asserts its therapeutic effect. If they don't, there's always an academic group who will. And usually we can find this information. But if there's something that's missing, just note that the internet couldn't find it. Make an effort to find it. And you can do things like list the drug and ask the question: how does, in this case, Tramadol, what is the protein binding of Tramadol? You can ask that question, and you'll get a lot of answers. Okay. So bear in mind that we can, and you may have to ask the question based on the generic name of the drug. These are brand names. They all have generic names. So be aware that you may have to do a lot of your thinking based on the generic. So the manufacturer used the brand name. Because if you just pick the generic name, you're going to get, you may get the right manufacturer by that, but you might just put random manufacturer. Okay. Patient assistance programs. Drugs are expensive. I know that's a big shock to you. But drugs are expensive, and many of them, especially more expensive drugs, aren't even covered by insurance formularies, or if they are, they're covered with a prohibitive. A couple of years ago, year and a half ago, I was picking up a local Walgreens for my mother. And as I was waiting in line, an older couple came up, older man, and turned in a prescription. And heard the farm tech who went and checked, because what they do is they'll check, they'll come back to you and say, well, that's, your copay is going to be. She came back and said, your copay on, and she named the drug to this patient. And I'm standing with an earshot. This is probably about, I was a HIPAA guy. But, you know, it was a small pharmacy. It was almost impossible because the text said, your copay on this drug is going to be $849. And I thought the woman was going to, she almost started crying. She was there with her husband. And she almost started crying. And she said, I can't afford that. You know, and I knew the drug, and I knew that she probably did need to have it. So the pharmacy technician, I don't know, you're gonna have to talk to the doctor. I saw it finally. I said, I'm sorry, I don't mean to be listening in on this, but I named the company that manufactured the drug, and I said, contact them. They may have a patient assistance program that would either give you the drug significantly cheaper or possibly even the farm tech didn't know it. And to me, that's, I was not impressed with that. And then, just really makes it sort of even more bizarre. About 10 feet away, a woman in her probably 40s said, yeah, my daughter had that drug, and that's what we did. And we got a lot of help. So, I mean, we could have that little basically right there because it helps people. But patient assistance program, this is how the companies are trying to get around the best is providing these patient assistance programs. You know, a number of people benefited. I had a student a couple of years ago whose husband had some very unpleasant disease and was in a clinical trial for a drug that, when it finally got marketed, was about $5,000 a month. And they rolled him over into a similar clinical trial because they didn't have it. He was out of work, he was a student. So they had nothing. That was good. But they are, it depends on the drug. Inexpensive drugs are not likely to have a patient assistance program. Expensive drugs are very likely. And the reason these programs work is that for the rest of the population that are taking these drugs, their insurance is poor. Their insurance is paying for it. And so there's little incentive to lower costs. So they try to ameliorate that program. And you have to sort of, you have to try to get into them. There's no guarantee that you will get. So Okay, questions? Okay. All right. Okay. Let's start talking about antibiotics. Okay. The let's if we look at if we look at drugs, just going to go back and make some other general comments about the use of drugs. Even though the FDA were very specific that are supported by clinical trials, doctors, it's perfectly legal for doctors to use drugs for other purposes. I mean, in reality, there is no for a doctor prescribing any drug for any purpose, for any patient, in any amount, on any schedule, by any route of administration, because medical practice is to provide information to many drugs are approved for 1 year. Very few drugs are so exquisitely targeted, although we have more and more of the technology. More and more, more and more usage. Usually, usually a patient will come in suffering from two or three different conditions at the same time, and a drug will be one of them, and both or all will improve. And so that's how we discover some of these. And those improvements then get reported. Get reported in a medical journal. Every medical journal has a section of communication. They have very different, but basically letters. Then what you doctor can say, this disease, occasionally approved disease, and that usually prompts to think about using a drug in a different way. We call that off-label use because And as I say, any doctor can do that. But they have to ethically, they have to be reasonably certain that it's going to help the patient. And this usually is based on either the kind of accidental discovery that I just described, generating a letter to medicine, or colleagues going to colleagues meetings and learning these things. So we have a lot of different uses of drugs that are that way. They make their way into the literature. Pharmaceutical companies or someone may sponsor a clinical trial. We look at different kinds of drugs that that work by different kinds of mechanisms. Drugs can induce activity of enzymes. They can, we call those agonists, or induce something happening, we call them agonists. They can block something, we call that an antagonist or blocker. They can mimic something. Mimetic is another term meaning something that mimics, and those are often agonists will mimic the activity of another component of the body that normally activates that system, works on that receptor or whatever. Neurotransmitters are molecules that are released from the end of one neuron and cross a facial gap chemically to attach to the next neuron, activate that. That's the basis of neurotransmission. So we have those kinds of terms are used. Drugs are classified by the way they act. We can have drugs that act with the blood pressure, and we've got about 5 different mechanisms by which we can do that in the body. These are all called antihypertensives. We have drugs that can have broad therapeutic effects, like pain relievers, analgesics, we call those. We have drugs that will affect body systems. The genitourinary system, for one, the cardiovascular system. They can also have very specific effects on fortunes. Your drug might directly affect the kidney as part of the genitourinary system, or might directly affect the heart as part of the cardiovascular system. There are thousands of drugs, okay, as we've said, plus an enormous body of facts. Medical knowledge doubles at least every 2 years. Doubles every 2 years. It's impossible to keep up with that. So what we look for are general concepts that we can use to predict the behavior of drugs. For one, if we want to lower blood pressure, one of the first things we give our patients is a diuretic, something to a water, something to make them excrete more water. One of the complaints about them, of course, is that they need to take it to the bathroom every time, and it's something that leads to non-compliance, especially in the elderly. So you have to again be aware that these things occur. But we can look and knowing that we can know that we know that there are diuretics that work in different parts of the kidney nephron. They might work in a loop, they might work in another portion of the nephron. But the effect is largely the same. The effect is to lower the plasma volume by getting rid of urine and thereby lower blood pressure. Because one of the components of blood pressure is the plasma volume. Okay? So if we understand a few basic principles, we can make some predictions. Are our predictions going to be 100% accurate? Probably not, but we can be pretty clear about a lot of things. We have when you are thinking about a drug, when you think about experiences that you know people have had, maybe family members, or what you've been reading and studying, do we need to know the details, plasma concentrations, etc., of every drug? Absolutely not. No way we can. Nobody has that good memory. But what we can do is know that our drug, whatever the type of drug it is, we can make some guesses. For instance, if someone says, I'm going to put you on atorvastatin, which is a cholesterol lowering drug, the statins all work by the same exact mechanism of action. So you can then predict what would happen if someone took one of these drugs. Is that prediction going to be perfect? No. It might end up being a little. Or you may find out, as we did recently in our family, that statins don't work on women. So there are gender differences in drugs. So the differences in the use of different drugs in a class might be dependent on what you're trying to achieve. Some drugs are going to have multiple doses per day. I mean, beta blockers are a good example, anywhere from 1 to 2 doses. Statins are all pretty much the same, 1 dose a day. But other cholesterol lowering drugs, the fibrates, for instance, you might have to take 3 times. But they have different side effect profiles, and they work by different mechanisms of action. Why, sometimes you're going to ask, is it okay to give this patient an oral drug, or do I have to give them an IV drug? The question here is, how fast do you want to take? For instance, a patient goes into the ER with what we call unstable angina. Angina is a painful heart condition where the heart muscle is not getting enough oxygen. There are several different types of angina. Angina is one, and that happens when people have it. Obviously, they stress their heart by exercise. Unstable angina is the kind of thing that comes on basically sitting in a chair reading, and this heart pain starts. It's very dangerous. We usually have patients that have angina will take nitroglycerin tablets, and it takes 3 to 5 minutes for a nitroglycerin tablet to relieve the pain. And if it doesn't work 3 to 5 minutes, take another. And then, depending on what the doctor told you, either you try one more time or you have to. Unstable angina doesn't respond very well to that. So a lot of times what we'll do is they'll immediately put them on a nitroglycerin IV, because basically you have an immediate response. And the way it works is it relaxes blood vessels and allows blood to flow more freely, carry more oxygen, and that's how it reduces the pain. But, we have to look at, whenever we're looking at a drug, what is the goal? How immediate is the goal? What's the long-term goal? So we have drugs that are grouped in basically families of drugs. Um, the if we look at at drugs that lower blood pressure, antihypertensive, we have beta blockers, we have angiotensin converting enzyme inhibitors, we have angiotensin receptor blockers, we have diuretics, we have calcium channel blockers, all of which can be used to lower blood pressure, but they fall under the general family of antihypertensives. We don't just throw all of them at every patient. Usually what happens with hypertension patients is that the first thing you'll throw at them is a beta blocker, unless you know they're retaining water. They have edema, swelling, usually of the ankle. And the swelling is measured by how big and persistent a pit you can make when you push on the flesh, how deep your finger goes before it hits something solid, usually bone around the ankle. And if you let go, how fast it would pitch. So that's pitting. And there's a scale for those. I'm not real familiar with that scale. But each of those has a different mechanism of action. So we'd start with a diuretic if swelling was an issue, if edema was an issue. If not, we'd probably start with a beta blocker. Why? Because they're gentler drugs. They've been around a long time. We understand. If that doesn't work, instead of switching, because hypertension is not just a single cause. It's a multifocal disease potential. It can be a lot of different things causing it. We may want to go to an ACE inhibitor next. So again, we're looking at how we classify the drug. We have major classifications. So there's cardiovascular drug is a major classification. Take it down a level, antihypertensive. Take it down a little, diuretics, beta blockers, etc. The same with many of the different systems. So our classification of drug depends on the system they're working on, the very specific conditions that they treat, and mechanisms of action. Okay, so I said before, if we want to lower cholesterol in patients that are mild, that have relatively mild elevation, say between 220 and 250 cholesterol level, you get up above 300 and you run into the issue of the drug there's a genetic component. But at mild cholesterol lowering, there are three or four major families of drugs. Then there are the agents that literally are not absorbed. What they do is absorb cholesterol from the gut. So they absorb it from the gut. And then you have fibrate family different currently, everybody's using statins. Nothing wrong for lowering cholesterol, but it's all right now depending on that. Actually, drugs can do a lot of different things. Most commonly, we have our non-steroidal anti-inflammatory drugs, aspirin, ibuprofen, that relieve pain, relieve fever, and relieve inflammation. These can be very related conditions. Okay. We're going to spend some time talking about antimicrobials, and we'll stop here for today. But we'll spend time on Wednesday talking about the very, very large family of drugs. Meanwhile, Yeah. Here we go. Your antibiotic comparison chart. You can start on these if you wish. And these are antibiotics. So the list itself does not contain any fungals. Antibiotics mean antibacterial. Okay? So we have, so it's not including drugs for treating viral infections or protozoal infections. Remember, our basic families of microorganisms are the bacteria, archaea. We don't talk about archaea because there's no disease involved with archaea. So bacteria, fungus, algae, protozoa, and virus. 5 major families of microorganisms that we see clinically. Very few algal diseases, although algae has a big effect economically, periodically. We have algal blooms in the ocean, and what happens if the ocean gets the right level of nutrients and the right temperature, then algae just starts growing like crazy. They grow so fast, it's like watching a stop motion or a slow motion opening of a flower. So we call it a bloom. And what happens is shellfish eat the algae. The algae generates a toxin inside the shellfish that doesn't hurt the shellfish, but kills humans. Called cytotoxin. So it has a big economic effect. Very few, we can get some algal disease, but very rare. And the fungus family, remember, contains both molds and yeasts, okay, as well. So looking at these drugs, I want you to start thinking about this. We'll talk more about the antibiotics on Wednesday, and it will cover a lot of ground, including antivirals. We'll talk a lot about anti-infective diseases, anti-infective drugs. It may be the largest class of drugs we have, just in general. And it also comprises probably universally the largest portion of all prescriptions written is for infectious disease of one sort or another. And that ranges throughout. Now we have so many new antivirals that those are coming in as well. So, questions? Okay, so today we covered just the basics of pharmacotherapeutics and pharmacokinetics. Remember we talked about pharmacodynamics in the last class, pharmacodynamics, the mechanism by which drugs actually exert their therapeutic effect on the body. You're going to be dealing with that with this chart, mode of action, and with the ADME component of this of the assignment that you're doing. Okay, so you'll be dealing with that. Okay, I guess that's all. So you'll have a quiz this week. You have your discussion. I would advise you to wait for the quiz until we finish with the lecture on Wednesday. The discussion you can start to work on. Think about now because it's about admin. But think about the different stages and maybe do a little research. You'll find a lot of information in your text that will help you with that. I will have more handouts for you on Wednesday. Okay. We'll see you then.
All the videos, are we gonna go through them, or do we go through them ourselves?
I would like you to go through those on your own because they'll also help you with the assignment.
quiz.
Yeah,
Can't actually act in it.
you can't.
It's like a PowerPoint.
Yeah, it's a PowerPoint. I think you can, at least. I think you can take the quiz in that. I'll have to